In your handout, I'm going to go through a couple things and then we'll start the program just so you know what is there. This program will be on the website, but if anybody has a burning desire to get it tonight, the handouts that I'm providing, you can email me and I will indeed send them to you as quickly as possible, which would be as soon as tonight or tomorrow morning. There are a couple of other things that are in your handout that may help you in terms of understanding the documentation and coding process that we're going to be chatting about today. This is kind of a flow sheet that talks about what happens in behavioral health. Is it an E&M alone? Is it E&M and psychotherapy? Or is it psychotherapy alone? And as you're going through and reorienting yourselves, your clinicians, your practice, and your process, this may help you get a handle on what coding might be used in which scenarios of care. The other thing that I provided was a kind of an audit cheat sheet that is used by someone like me that looks at things like what are part of the visits that we're going to be chatting about today. And so this document is how you might review and audit on the E&M services that we're chatting about today. So those are some things that are provided, as well as a discussion about one of the hot topics that we'll all enjoy when we get to here. It's called interactive complexity, and what that means to what you do in behavioral health, whether it be children, addictive medicine, whether it is a discordant process. This is a whole concept that you're not used to coding in your current world. So with that said, let's start talking about our program today. And unfortunately, here we go. My name is Diane Zucker. If any of you ever heard me talk, I'm pretty informal, and I do walk and talk, and I'll try not to walk in front of the podium. As I said, if you want to get the program early, handouts, just email me. Our agenda today is very filled with information and process. We're going to be talking about, you've already heard about the introduction and about this transition. And I know many of you are sitting there saying, well, what are the policies that are going to be part of all these codes? And why am I learning about the codes before I learn about the policy? Well, it's kind of, a cart or a horse. You have to know both of these things. And as I'm talking today, one of the things I want to stress for all of you is that this change in documentation and coding impacts your entire process of how documentation is performed, who does it, how it's done, what the flow is. And so after today, you're not all going to go back and know the exact elements that are part of a 99215 or a 99213, but what I hope you gather from today is about the process and about the continuity of how that documentation happens and what you need to do structurally in your locations to make sure that you've got the stuff and the elements to code and bill correctly under the new scheme of life. And so when we talk about CPT coding, how many of you here own a book? It might look like this. Yay, I'm glad to hear that. For those of you who don't own a book in your agency or in your process, you probably ought to go and get one. Now, if you said to me, can I go to Half Price Books and get one used? As long as you get one that is later than 2013, those are the codes that are most important. There have been changes over the last, every year there's little refinements. But to start off until 2017, you want to have one that is at least since 2013 on. How many of you here are clinicians, physicians, CNSs, social workers, all those kinds of folks? Good. I'm glad, because you're the ones that are going to have to be working and spearheading the documentation and coding changes with regard to this. How many of you here are administrators? Okay. Anybody here a certified coder? Okay, we've got some. And the reason I'm asking is that Mary wanted to know kind of who was in the audience. It is, for some of you, this may be a total change from what you're used to in terms of documentation and coding. And it is a change because as we transition to the new Medicaid world, we won't be worried about time in the way we are today. We still are going to worry about time, but not in the same process. So this is our agenda. We have a disclaimer that I have to present as always, because we are going to be talking about the American Medical Association CPT codes, and they are the ones who actually write these codes. The implementation of how the codes are used varies by Medicaid, Medicare, whatever. Not the code use, but the code coverage. So as we talk today, and remember, for those of you who have a portion of your agency that sees a Medicare patient or sees some commercial insurance company patients, the rules that we're talking about, evaluation and management or documentation of therapy or add-on codes, those rules are used consistently by just about every insurance company and commercial land out there. The variance may be how they pay them, and the variance may be on coverage limitations, but the code structure and the code process is universal. That was part of HIPAA a few years ago. So that disclaimer identifies that if you are talking about a U.S. behavioral health patient versus Medicaid versus Medicare, it is very important to know who that patient's coverage is with or that client's coverage is with. Our acronyms in healthcare and coding and documentation are pretty standard. The CPT, Common Procedural Coding, E&M, Evaluation and Management, which we are going to spend a lot of time on today because that's the driver that Medicaid wants to shift patients to and clinicians to. Family history, history of present illness, HPI, or interval history, ICD-10. You're going to hear me say a few times today, and someone got a little nervous yesterday, about the importance of being specific with diagnosis coding, about not using the unspecified codes because the acuity of the care that you're providing, that medical complexity has to really tie into the specific diagnosis coding. And that needs to be consistent through your agency. If I have a physician using one form of bipolar with manic, and the social worker is using bipolar with depression, I have a problem there when I'm adjudicating those claims or looking at that process. Medical decision-making, MDM. And I'm going to say this over and over again, that when it comes to evaluation and management service, the key driver of the coding should always be the medical decision-making, whether it's by a nurse practitioner, a CNS, a PA, a physician. Medical decision-making should always drive the level of care. When it comes to what a mid-level provider is, when we talk about evaluation and management services, a mid-level provider is considered a nurse practitioner, a CNS, an advanced practice nurse. In some of your world, you may use physician assistants. Those are all MLPs in terms of not fully a physician, but able to practice independently in terms of licensure and seeing patients independent. A PE is a physical exam, but that does not mean that you have to pick up a stethoscope and listen to my heart and lungs in mental health. It means your psychiatric examination of me in terms of my thought process, my hallucinations, all those things, my mental status, orientation. That's what that physical exam is. PMH, past medical history. ROS is the review of systems, and that is where the bug is in evaluation and management services between psychiatry and the rest of the medical world, because many of you do a psychiatric review of systems, which is different than the medical review of systems that will be required as we move through the E&M services if we are coding things at a higher level of care. And then, of course, social history. Now, the changes back in 2013 were done because the American Medical Association and the American Psychiatry Association wanted to uniform how documentation and coding happened, not only for psychiatrists, but for all kinds of medical providers. If some of you think back to the old days, there was one code that had psychotherapy with E&M, psychotherapy with E&M, and interactive complexity, and they had all of them smushed into one code. And what happened in 2013 was they began to separate and say, here's our evaluation and management, here is our psychotherapy add-on code, and oh, by the way, here's our interactive complexity process. That decision to separate those codes out into 3 codes instead of 1 was with a lot of careful thought, and also dealt with increased reimbursement on the Medicare side and on the commercial side of care, which did not have, it was not just we're going to make 1 code, 3, and have it all be the same. It really did increase the revenue in the long run if the documentation and coding supported the care that was provided. And so there was a deletion of med management, which is when we talk about the med management code that you've been using in your agencies. That has not existed for commercial insurance or Medicare since 2013. We will be talking about interactive complexity, which is a concept that was expounded in 2013. And it also changed how we look at time for psychotherapy. Back in the bad old days, you had to spend exactly 20 minutes to get to that one code. Now, with the revision in time coding for psychotherapy, there is a range from 16 to 37 minutes. And so the importance of time is still in your documentation, but it is not as rigid as it was in the old process. And that's a good thing, because sometimes you spent 19 minutes, not the full 20, and technically I could not have billed that psychotherapy if I had not achieved the full 20 minutes. When we look at documentation of care provided, and I always start off a program talking about how you document what you're doing, because as we talk about coding, and as we talk about what a 99214 is, if it's not documented, if all you do is pick a code, then that is not what we need to have. I also have to have a moment of silence here and talk about what is the medical record. Okay? Now, I say this to every program that I present. I should not exist as an auditor for your records. You should never have to bring someone in to say you're doing it right or wrong. You as clinicians should be documenting the quality of care that you provide, and somebody shouldn't say you missed a review of systems or you missed a history. But we're not there yet, okay? So that when someone says to me, what's the most important thing about your documentation in that note today, and that's what we're going to be chatting about till 4 o'clock or so, is the quality and the substance of what you're writing about Mary or Mike. It is their pertinent history, their pertinent exam, and those things that go into making that treatment plan and providing the care. Some of the razzmatazz that we have to put into a note to get to that right level may not be things that you necessarily want to do, but we have to if we're going to code and bill our services correctly. And so when I say that, I really mean that when I look at your notes, I want to see substance. I want to see what's happening with that patient. Not a cloned note, not a replicated note, but the real patient behind the services that you are providing. And so when we look at that, that's where some of the things that you provide. Right now, you have to have clock time because the way the state of Ohio pays for behavioral health. In the New World Order, clock time will not be as important except in a few circumstances. Yes, you will have to document time for your psychotherapy of 16, 18, 20, 30, 45 minutes, whatever it is. But when it comes to the evaluation and management service, that care will be based on the history, the exam, and the medical decision-making that is pertinent to that patient's care. So time will be important for some things, but not for the E&M services. Okay? Now, when we look at electronic medical records, how many of you here are using electronic medical records? Are any of you here still on the old-fashioned paper charts? We have a few of you. Okay, and that's okay. Paper is still good. Okay? It doesn't crash. It doesn't burn sometimes. But paper is still good. But when we talk about the importance in the electronic medical decision-making world, even the paper world, electronic medical records bring with them a blessing and a curse. The blessing is I can sit in Rocky River and read notes all over the country. The curse is sometimes we take shortcuts with our electronic medical records. Sometimes we don't follow the rules, and sometimes we do things that we probably shouldn't. And so things like how data is entered. But this is also true in the paper world. I cannot have the history of present illness written by a nurse in a paper chart any more than I can in an electronic medical record, because there are some things in E&M land that have to be documented by the clinician. So that even though you may not be in an electronic medical record, the rules of how documentation happens, about how processes are in place, about signature, about all these things, co-signing of notes, note closure and completion. If you have a provider who has not completed notes from 3 months ago, you can't bill those whether they're paper or electronic. And so because the electronic world has made us easier to cheat sometimes, but the rules are still the same in terms of who can document what, where, when, and how. And so as we go through today talking about E&M, remember, whether you're electronic or paper, these rules do apply. Electronic medical record or paper record. The protected health information is that information that's individually identifiable to me. And where clone notes get really problematic is when I see the same note for every single one of the Suboxone patients without any variation on Jim from Jane from Julie. And so we have to remember that by protected health information has specific stuff that is pertinent to that patient. Authentication ensures in an EMR who is documenting and providing that service, who is signing that. And I always tell every program that I do to go back tomorrow and make sure that whenever you're signing a note, whether you're an RN, an LPN, an MD, a DO, and a CNS, to make sure that your degrees print when you electronically sign that note. And that your authentication is very clear. A few months ago, I was in a setting where the name was right there, but no degrees. And they were wondering why there were some problems with their claims processing. And it was just something that didn't get set up correctly. When I have handwritten notes, same deal. I have to have my MD, my whatever it is after that. The signature identifies the responsible party. And for some of you, when I have supervision, I have to make sure that not only the provider signs that note, but the supervisor signs that note. So if I'm having a nurse give an injection, that injection has to probably be co-signed by a physician or a nurse practitioner or a PA. And so I have to have the ability to make sure that we have that co-signature as well as signature process in that document. When I look at cloning of notes, and that's where I see replication over and over again, I use a standard template. You need to make sure that the notes are unique to what happened today. And that they are not just a continuous process of the same note over and over and over again. And this also refers to diagnosis coding. When someone comes into intake and a diagnosis is assigned, that may not be the diagnosis that shows up on their treatment plan, or their treatment plan may change halfway through their time with you. We really need to make sure that whatever goes on that claim form is what is in that progress note and is updated on a regular basis. If I come into your agency as a catatonic schizophrenic, but I go to remission or partial remission, that code should be changing with that patient's status through their healing and health process. And what I see oftentimes is the diagnosis they're assigned at intake is the diagnosis that covers them forever. And I had one that was 11 years, same diagnosis, even though there were other things that were happening along the way that changed that process. Cloning in Medicare. Medicare has some very clear guidelines on Medicare about what is and is not a clone note. There are times when I have no problem with carryover and bringing over things from prior notes. For those of you that have treatment plans that are part of your EMR that actually attach to that progress note, I have no problem dropping those in as long as there's a status and a process of how they're doing on that visit or that encounter. And the update and change. If you have a patient with a continued process or plan for medication management, that plan may be the same from visit to visit to visit. But I do want to know when you carry that over, how are they doing today? Are they better, worse, about the same? Have they backslid? Have they, what's happening? So that if you're going to be using the standard process, making sure that you identify what's going on at that day. It may be different than 2 weeks ago. Okay? Over documentation. You've all seen this, I know. You've gotten records from someplace else where the only thing that you read as clinicians is the last page, what the assessment plan is. Or maybe the first page where it says the history and then the last page, because all this other stuff that is in that record. Just because a note is 5 pages doesn't make it any level of care. The level of care is based on the substance of that note. In behavioral health, there are things that you're putting in notes that may make that note longer that are acceptable because you may be putting things in for tracking purposes. You may be having things in there that you're due just so that you can track interagency process. That doesn't necessarily change that level of care, higher or lower. It's always based on what that medical decision-making and pertinent history and exam relate to. In EMR and EHR templates, or if you have standard forms that you use that are like a template, those templates are just fine as long as they are customized to meet that patient. And in a number of my practices that are still paper, they've always used the standard form, and they make sure that anything that's important on that form is filled out, and then they base it on what that form says. And that's okay. So don't be afraid of templates, but make sure that you use them correctly. And make sure that they're used consistently through your processing agency or that program that the patient is in, so that you get the documentation you need to achieve those certain things like time for therapy or interactive complexity. Okay, let's talk about CPT coding. Now, here we are, this book. How many pages do you think you're going to be using out of this book? Not very many, okay? The CPT codes are all 5 characters long. And I did not mention this yesterday, but I'm going to mention it today, is that when you look at these codes, okay, the ones that are important to you that we're going to be talking about today start with 99, which are the E&M codes. Some of them start with a 90, like my psychotherapy codes, my 90836, or my interactive complexity. Those are all in that, like 4 pages of the book. Family therapies, group therapy is in that family. Now, you may never use any of the other codes that start with 0 because you're not doing anesthesia, but there are some codes in there that we may be using someday that talk about autism intervention. Okay? But they end in a T. Okay? If any of you are doing any PQRS, quality improvement measures for Medicare, those codes all end in F, and they can start with anything. Okay? But you're not doing surgery that starts with 1, 2, 3, 4, 5, or 6 unless you do a blood draw, and that starts with a 3. You may be ordering x-rays or images. Those all start with 7. You may be doing lab work. You may be testing my blood or my urine for substances or for dosing. That starts with 8. Whenever you see a code that tells me, an auditor, or anyone at Medicaid or anywhere, what you are doing, in this book right here, none of the HCPCS codes show up. Those are all on the internet or in a different book, and you can actually download all those for free. There is a concept in CPT that we're going to talk about now with coding, and it is called add-on code. And this concept is when 2 vowels go a-walking. We all go back to our elementary days when we learn about 2 vowels go a-walking. The first one does the talking. Well, the first one that does the talking is the primary code. Okay? It might be an E&M code, a 99214. And then there may be an add-on code that would always be coded second to that code. In E&M land, it may be prolonged service, that your time with me today was an hour and a half doing that med management because of everything else that was going on. And so I might be adding on a prolonged service code. If I was doing an E&M, a 99213, with psychotherapy, that psychotherapy is an add-on code. In the definition of the add-on code, it says, always code in addition, okay, to the primary procedure code. That's that first vowel, okay? And it can never be coded alone. It always has to have a pal with it. And it does not need a modifier for anybody in coding land who wonders about modifiers and add-on codes. Okay? And there's always a notation about adding that, whether it's prolonged service, whether it's psychotherapy, whether it's interactive complexity. You're adding that on to a primary code. And so that's a concept in behavioral health that is very important when we talk about psychotherapy, E&M and psychotherapy, and interactive complexity. Okay? So E&M services, evaluation and management. What is a new patient with respect to evaluation and management? Well, it is a patient that has not been seen in your program within an agency for 3 years and a day. For Medicare purposes and commercial insurance companies, it's 3 years and a day for your tax identification number. But Medicaid will be tweaking how that's perceived in terms of agencies that have multiple programs. And so it's one that has not been seen for 3 years by that same classification of person. An established patient is one who's following up. These two codes have nothing to do with case closure or reevaluation. In the psychiatric coding section, the 90871 and 90872, which are the diagnostic assessment codes that you all are using now, those codes do not have a new or established criteria. What the criteria for those codes are is I can't code a new diagnostic assessment unless that patient's case has been closed, or they've been a no-show, or they've been inactivated. And then I might be able to do a reassessment on those diagnostic codes. It's not to be used for a yearly checkup or a yearly reeval. That in CPT becomes part of that ongoing E&M or E&M with psychotherapy. So it is important to know that the psychiatry codes do not have a definition about new or established the way the evaluation and management codes do. So E&M codes really are, I'm new if I've not been to your agency for 3 years and a day in that specific program. And so when you're looking at the guidelines that Medicaid will be putting out, that will be an important one to see how that's defined for agencies that have multiple programs and multiple streams. When we have CPT for behavioral health, these are the codes that we're going to be looking at and really talking about in terms of E&M. Medicaid will still have some HCPCS codes, but these are the ones that the clinicians will be using for E&M. Notice that there are 5 levels for a new patient or 5 levels for an established patient. Also notice that each level has criteria: problem-focused history, problem-focused exam, straightforward medical decision-making. This terminology is uniform between all evaluation and management services that you provide, and across all evaluation and management services, no matter what location of care you provide them in. We are going to be talking about the office or clinic codes today, but if any of you ever did things in assisted living or group homes or custodial homes, the codes are not the same, but the definition about how much history, comprehensive history, or how much exam, comprehensive exam, or medical decision-making is uniform across the entire coding set. Notice that there is time associated with all these CPT codes. Okay? We will talk about time at the end as it comes to an E&M code, but if you have a patient that you see that has high, complete, comprehensive history, comprehensive examination, and has high-level medical decision-making, and you only spend 40 minutes with me, not 60, by E&M guidelines, you can code the code and the service that you provide without having the time, there with the patient. Because sometimes you can do that whole process much faster than 60 minutes. 60 minutes is used when I have to use time in some cases. So the scenario would be you have a patient that has moderate medical decision-making, but you're doing a lot of counseling and education and a lot of other stuff. And the time with that patient is, maybe 70 minutes. That would be the time where documentation of time and the use of the code would be documented a little differently. And that's going to be the exception rather than the rule. Nurse visits are the lowest level on established patient visits. And a nurse visit for Medicare for CPT coding purposes may not be, it may be actually anyone in the state that is identified a clinical provider. For Medicaid purposes right now, that is an RN or LPN for the behavioral health side. So that a nurse visit, notice it's typically 5 minutes, but it has the same criteria of a very focused, history exam, a nurse visit, education, perhaps testing. Now, the established patients, there's 4 levels that a clinician might be using. Level 2, level 3, 4, and these also have the same criteria. Now, what's different in the new patient is that you have to have all 3 things at the same level. And this is where I like to use a visual. So if I'm going to code the highest level you have to have the history and the exam and the medical decision making at the same level. If one level is lower, then it drops to the lowest common level. Okay? When I comes to established patients, I either have to have history or exam at the same level as medical decision making. And I am very much focused on making sure that you understand that your electronic medical record, if you have all the bells and whistles filled in, will make every single visit a level 4, when the medical decision making may not be. And so I tell physicians that no matter what your electronic medical record is, medical decision making should be the driver of care, especially in behavioral health, because you may have information in there from other sources that enhances that process, and the medical decision making isn't really at that level, but the bullet points are. And so when I educate physicians and clinicians and practices and administrators, I remind them that you should always make sure that medical decision making is one of those two things that you're using today, deciding I'm a level 4 or a level 5 or a level 3. Not just say I've got the history, I've got the exam, but also make sure that I've got all the components. So if I have a detailed history and no exam, but great medical decision making, I would be coding that based on that two things, that detailed history and that medical decision making. Ideally, you're always going to have some exam, some documentation of face-to-face with the patient. Healthcare is a puzzle, okay? And when we talk about the evaluation of management services, this is where I remind clinicians of all types that what you do in patient care goes beyond the 25 minutes that you are with me in the room. And that's the hardest part to get clinicians to make sure that they've documented enough. It may be the diagnosis, new onset, deteriorating, complicated by heart failure. It may be what happens after the visit, that phone call to the psychologist or the social worker, that phone call to the daughter, the son, the caseworker, the court system. That evaluation and testing or coordination. Yes, you've seen them, but now you want them to be evaluated by somebody else, or you want to pull in information from their primary care. And then there's what you do in your agency, the coordination of group therapy, individual therapy, med management, and all those other things. And if you've done a good job of making sure that that puzzle of patient care is documented, then your level of care, whether it's a level 4, or level 3, or level 5, will make sense in terms of the algorithm of what you're doing. But again, remember that what you're documenting is what you're doing with that patient. And what I see when I audit charts is often physicians forget to tell me either that they're calling the primary care, or they've had a conversation before a visit with the social worker and things are deteriorating, or they've had 25 phone calls since the last visit and there's no mention of them in today's note about how that's changing your plan. And so those little things go a long way to talk about medical decision making and E&M stuff. Now, all care has to have a diagnosis, okay? And when I come in to intake, that diagnosis may not be known. And in ICD-10, there's a good way to know that you're dealing with a symptom, not a real diagnosis. If you're picking an R code for my bizarre personal behavior or my poor hygiene, now those R codes are all symptoms. If you're picking an F code that says I'm drug dependent, or I am schizophrenic, or I'm manic, the F codes in ICD-10 are all identified diagnoses. So that when I see somebody who's been in an agency now for 4 years, and when they transition to ICD-10, everybody is still using R codes, I'm like, no, we need to make sure that we've got the right diagnosis code. Okay? And so it may be that reason for visit, may be a symptom. It may be an actual diagnosis. It may be my dependency with mood disorder. It may be my depression with hallucination, my post-traumatic stress disorder with depression or anxiety. There is no rule out possible or probable in diagnosis land. If you do not have a diagnosis, use a symptom. That's fair game. ICD-10 does make changes every July that go into effect every October. This coming year, there are a number of changes, not too many in behavioral health, but if any of you have comorbidity that you're dealing with, especially in diabetes, you need to become familiar with those, both as clinicians and as coders. If a diagnosis is identified on a billing claim form, it better be mentioned in today's progress note, so that the errors that I see when I look at charts, I may see a diagnosis of anxiety disorder and post-traumatic stress and a beautiful therapy note, but nowhere is that mentioned in the progress note. They just put 311. It doesn't even correspond anymore to the diagnoses that you're using. Every note has to have a chief complaint. Recently, there's been a lot of discussion about who can do the chief complaint. That chief complaint can be entered by anyone. It could come from your billing, from your scheduling software. But it does have to be confirmed by the clinician. Okay? So if it says, I'm here for therapy, but you're saying, no, they're here for therapy and med management. Or if they're here for med management, no, they're here for med management and I'm going to be doing some therapy today. Pertinent history of what's going on, whether it's a history of present illness or interval history, that is whatever is happening today. Some identified exam. It does not always have to be vitals, though many of you with electronic medical records do vitals because that's part of what you're doing for quality improvement measures. And most importantly, if it's a time-based service, time, like therapy, time has to be documented. If there's an assessment and plan, every note has to have some kind of assessment and plan. Even if it's follow-up PRN, or follow up with your own psychiatrist at another agency, or case closed. But there has to be a plan and then the author. When we look at the chief complaint, this is what we were saying about the driver. What's that context of that person coming in? For nurse visits, the nurse should be identifying under whose direction that care is being provided. Med check, comfort care, whatever it might be. For therapy, I would have to identify the diagnosis for that therapy. Coming back for their anger management because of their explosive violent behavior, identifying. The reason for the scheduled visit may not always be what the end result was because patients happen. They change. You think they're coming in for X and all of a sudden it turns into something else. If any of you are doing group therapy or family therapy, there does have to be an identifying reason or title to that therapy. When it comes to cloned notes, and I don't want to call them cloned, but repeating notes, if you're doing group therapy and you have a set group process or even individual therapy with certain therapy topics that you are doing, those notes can be standardized, but there still must be an individual statement on each patient that is in that group. And if one patient in that group has interactive complexity, we'll talk about that in a few minutes, then that would be an additional comment on that patient's note. So that, yes, I might have a standard, even individual therapy notes, that you cover certain topics at certain points in their process, but I have to make sure that it is customized to how Mike and Mary are responding, whether they're meeting goals, whether they're at the objectives or not. Evaluation and management documentation, how it differs from the psychiatric is that there's a clarity in who can document what. In the psychiatry codes, when it comes to diagnostic assessment, this rule about who can document what is not really there. There's some expectation about the exam by the clinician, but it's not as rigid as it is in evaluation and management. In E&M services, all of your support staff, any of them, can document chief complaint, past medical, social, family, allergies, interactions, social, history, review of systems. So a patient themselves could document a lot of what's happening in some places, or it can be done by an intake person, or it can be done by a number of areas. It can be imported from other information. But the provider in E&M land must always document the history of present illness. There is no exception. The interval history or the history of present illness must be by the doctor, nurse practitioner, PA. They also have to document the examination except for vitals, and they have to document the key elements of the assessment and plan. If it is a shared team plan in terms of a treatment plan, they have to refer to it and how the patient progresses, but that can be a shared document. So what is, when we look at who can provide what kinds of services, in E&M land, evaluation and management services can only be provided by physicians, mid-level providers, APRNs, advanced practice nurses, CNSs, nurses. And a nurse can only provide an RN or LPN the lowest level of E&M service, a 99211. A nurse in E&M land can never provide an initial visit before they've been seen by a clinician, by a doctor or a nurse practitioner. In the psychiatry behavioral health codes, many of them are wide open, except the evaluation diagnostic assessment with E&M can only be provided by the physician, nurse practitioner, CNS, physician assistant. Counselors can provide an initial assessment without medical component. Anybody can provide any kind of therapy, and all providers can use interactive complexity correctly. And testing codes are based on what that designation is in terms of psych testing or other testing services in terms of their clinical background. So yes, a CNS could do psychological testing, or a social worker or a psychologist based on what their skill level is. General psychiatry and behavioral health codes are in the 90785 through 90899 section. Now I want you to think for a moment about what you do right now. Some of you do use evaluation and management services. Others of you use the diagnostic assessment code. And this is where there's maybe a shift in how that happens. The psychiatry codes in both therapy and assessment are not location specific. Evaluation and management codes are location specific. And I'll give you an example. All the codes we're talking about today are office-based codes. If you went to an assisted living location for outreach, you could not use the codes we're talking about today in that place of service. If all you were doing in that assisted living place was psychotherapy codes or diagnostic assessment, those codes can be used anywhere. Okay? That 90792 for the physicians and clinicians in the office can be used in any location. Office, hospital, homeless shelter, nursing home, group home, anywhere. E&M services are site-specific. So if your model changes and you're adding different locations, you'll need to get familiar with those E&M codes related to those locations. What's part of the code documentation? What do I expect to see in every note? Reason for visit, diagnosis, pertinent history, the rationale for interactive complexity when it is coded and billed, the identified care provided, E&M, therapy, or other intervention, group, individual. I expect to be able to look at the note and know exactly what you did and how that claim form came up with those codes. Time, if it's therapy, goals, objectives, plan, and process, and to be signed and dated. Okay? For those of you who use an electronic medical record, make sure that if you're not completing your notes on the date of service, and some of you may be a day or two behind, that date does not change up there in the header in terms of date of service when you've signed it at a different date. And I bring that up because I don't care when I do care when you sign the note. I do care. But the rule for it is really you just can't bill until the note's signed. Okay? And so there are some EMRs out there for whatever glitch. They may change the date of service to the date you signed it, and that may come up with some interesting variations on the theme. So, psychiatry and behavioral health. We already know that these are not new or established. And this is where you are right now. There's this new concept of interactive complexity. And that interactive complexity is a state of being. Has nothing to do with time, has nothing to do with anything. It is a state of being. And then therapy codes are in this same section. The diagnostic assessment codes, you all know what these codes include because you've been using them forever. The 90791 and 90792 in that assessment process, they're not new or established. The diagnostic evaluation alone might be that social worker, and those codes are going to stay the same. The one with E&M is the one that the clinicians use, physicians, nurse practitioners, and it has some medical thought. It may be prescriptions, it may be comorbidity with my COPD or my cellulitis of my arm from being a cutter, it may be my drug interactions, it may be a lot of things, but that has medical thought in it. It may be my past medical history of prior hospitalizations. It may be my familial history of thrombocytopenia and I'm a schizophrenic. It may be all kinds of things. And that medical thought has to be somehow documented. But there is nothing in there that says how many elements of exam, review of systems, past medical, social, family. There's no detail about what you need in that progress note. This diagnostic assessment, if you are following the state's guidelines in terms of what has to be documented, for the most part, always crosswalks for new patients to a 99203, where oftentimes the care you give is a much higher level, but that higher level requires more documentation. If it were a reassessment, it might equal a 99214, where based on what you're doing in some reassessments may be higher because of the patient's crisis situation. So that if you read this code, it doesn't say anything about the level of history, the level of exam, about having 10 review of systems. It does say mental status and other physical exam as indicated. So it doesn't say you have to have gait, station, motor exam, or even vitals. Where when we talk about E&M services, that is required when I'm billing a 99204, 205, the higher levels. My diagnostic interview requirements, it is much looser in terms of pertinent past medical, social, family. The psych exam has to be at minimum, a mental status exam. My recommendations would be the initiation of a treatment plan. That process in terms of goals, objectives, timing. Now, so when I look at the medical thought, that's where I have my clinicians that are adding those things about, it may be an additional exam, such as vitals. It may be tremors, gait, may not. You may add things about medication, coordination with primary cares. You may add those other things. Ordering of diagnostic testing, making referrals to neurology or wherever it may go. Those are all part of that medical thought process. And so if those codes are used, the expectation is that medical thought's reflected in that note. And that medical thought might be positive things. It does not, by the way, have to be a medical condition. It may just be that you're placing me or thinking about putting me on a medication that has side effects, which almost all of them do in terms of liver function, bleeding, whatever they might be, rashes. Additional medical workup may also be part of that medical thought. Ordering that lab work or getting that record from the primary care physician or doing that EKG prior to initiating medication. So medical thought is that process and the integration of maybe the medical symptoms with the psychiatric. Yep, I'm having palpitations that may be psychogenic, but you're still looking at those physical symptoms as well as the psychiatric. My diagnostic assessment has to have a lot of things based on what's out there. History, past medical, social, review of systems pertinent to plan, exam, diagnosis, and goals, and be signed. Now, part of the assessment, and this is where in the psychiatric behavioral health coding, a lot of this stuff comes from other sources than just the clinician, the physician, or CNS. It may come from the intake worker. It may come from the social worker. It's more of a team or integrated note. But these are all the things that are expected in terms of that diagnostic evaluation and that assessment. In E&M, these things count towards medical decision making as long as they're reflected as part of that plan and process.